Hello, my name is Dr. Audrey Cook, and I'd like to welcome you to my little course, Cooking with Fluids. This is lesson 2, in which we're going to be talking about fluid resuscitation. This isn't going to be a part of every fluid plan you make, but it certainly is something you need to consider each time you see a compromised patient. We talked in lesson 1 about the fact that it's really important we see if a patient has a resuscitative fluid need. What we're going to cover in this module is how we recognize that. And essentially, what we're looking for is signs of shock. When I say the word shock, what I mean is the clinical manifestations of ineffective circulating volume. So each time we see a patient who's relatively compromised, somewhat critical, this is the first question we need to ask. Now, there's lots of things that can clue us into a patient being in shock, so having ineffective circulating volume. But for me, this really is a patient-side clinical assessment. It's going to take you actually less than a minute. And yes, there's some lab work that can be helpful, and yes, there's some data like a blood pressure that can be helpful. But in all honesty, an experienced vet doing a quick assessment is the most reliable way to identify a patient in shock. And these are the signs that we're looking for. The first thing we're going to notice is a patient who is disinterested and poorly responsive, lying on the table, head down, doesn't care that he's there. The next thing you're going to notice when you lift the lip is that the gums are icky. So you've not got a good color. They're gray or muddy or dark or pale. But your first reaction is, ugh, this doesn't look good. You're then going to go ahead and check for a CRT, and this is going to be prolonged, meaning more than 2 seconds. You're going to grab your stethoscope, listen to the heart, and you're going to register that there's a tachycardia. Now, this is a very, very firm rule for dogs unless they have weird electrolytes. Cats are unpredictable. Cats can be bradycardic or tachycardic, so don't be fooled by a cat. You always want to be sure and feel for the femoral pulse while you're listening to the heart to make sure that every beat is accompanied by a palpable pulse. What you'll notice while you do this is that the pulses are weak. Whenever the pulse quality is disappointing, you always want to see if you can feel a distal pulse, like the dorsal pedal. As you grab that foot and try and find the dorsal pedal, you'll think, my, this foot is cold. You've just spotted the 6 cardinal signs of a patient in shock. So once we've decided, yes, I think my patient is in shock, and they don't have to tick all 6 boxes. Generally, if they've ticked 4, I'm going to say for sure this patient's in shock. I then have to figure out why. And I regard shock as essentially an end stage of a journey. And my next question is, okay, what got my patient into this predicament? Is this potentially a crystalloid loss? We see this very commonly. These are patients who've got bad vomiting and diarrhea or severe polyuric diseases. Blood loss or hemorrhage is another consideration. Could this patient have been involved in something traumatic or have, say, a ruptured splenic hemangiosarcoma? Got to think about cardiac compromise. Now, patients who have cardiac disease causing shock usually give us some very good clues on physical exam, like a heart murmur or an arrhythmia or their Doberman, but they can be tricky to spot. Distributive or vasomotor shock occurs when we get essentially collapse of the blood vessels, relaxation of the capillaries, and we see this in dogs and cats who have things like sepsis and anaphylactoid reactions. Obstructive shock occurs in patients who have conditions such as gastric dilatation volvulus, in which they're unable to get adequate venous return back to the heart. Now, when we recognize the patient's in shock, our instinct is usually to go grab a bag of fluids, but we have to pause for a second and think, ooh, are fluids going to be helpful? So let's put up those reasons for shock again and have a think about which ones are going to be helped by fluids. So let's look first at crystalloid loss. Patients who've got crystalloid loss causing shock, yes, they're going to feel an awful lot better if we administer a fluid bolus. That's going to be potentially very, very helpful indeed. How about blood loss? Well, we might see some improvement. It's probably going to be transient if the hemorrhage is continuing. How about patients who've got obstructive disease? Well, kind of the same thing. They may get somewhat better, but then they're probably going to take a step back down until we address the obstructive process. Patients with distributive or vasomotor shock really do need some kind of pressor therapy, and so we probably aren't going to see much of an improvement in those patients. And as for those with heart disease, absolutely not. We will make them 100% worse. When I think about a resuscitative fluid plan, my default or my standard is going to be to use crystalloids. I'm going to reach for a replacement style fluid, meaning a fluid with a sodium concentration that approximates that of plasma. And I think for various reasons, LRS is a great default fluid to use. It's a balanced electrolyte solution and it's buffered. One thing I would say is that this plan is a very safe plan if the patient's sodium is between 130 and 160 millimoles per liter. If that's not true for your patient and you think you have to do a resuscitative fluid plan, you need to find or make a fluid that is within 10 millimoles of the patient. When we're thinking about using crystalloids as our resuscitative plan, so the standard plan, we often talk in terms of what is the shock dose. And the shock dose is basically the blood volume. And so for dogs, we use a figure of 90 mils per kilo. This is the maximum amount of fluid you should give in the first hour. We generally give a quarter of this over 15 minutes and then reassess. This may be an overestimate for dogs who are significantly obese. The volume for cats is a little bit different. In cats, we think in terms of a shock dose of 60 mils per kilo. And again, we'll tend to give a quarter and reassess. One thing I would say is to be very cautious in hypothermic cats because sometimes they need a lot less fluids than we think. Now, there are a couple of alternative options when it comes to giving resuscitative fluids. One option is a plan that uses a colloid. Generally speaking, I tend to think of colloids as having kind of 4 times the punch of a crystalloid. And so the dose we use for a colloid is about a quarter that we'd use for a crystalloid. You can, if you want to, do a mixed plan that uses some crystalloids and some colloids. Hypertonic saline is occasionally used as a resuscitative fluid, but that's usually only helpful under specific circumstances and not a routine approach. I do want to take a moment to talk about additives in resuscitative fluids. It is always perfectly okay to go ahead and add dextrose. If you want to make a 2.5% solution, you need to add 50 mLs of 50% dextrose to 1 liter. One thing you must never do, however, under any circumstances, is add potassium when you're giving resuscitative fluids, because it's very easy to exceed the Kmax, and then we risk simply stopping the heart. After I've gone ahead and given my quarter shock dose as a 15-minute infusion, I'm going to go ahead and reassess my patient. I'm going to pay very close attention to mentation. I'm going to see what's happening as far as parameters such as the pulse quality and the heart rate and the blood pressure. And I'm going to be faced with one of 3 outcomes. Outcome number 1 is the patient looks significantly better. This would be fabulous, in which case I would go ahead and proceed with working on my replacement fluid plan. And we'll talk about that in another module. Now, it's possible that the patient looks kind of sort of about the same. Now, if that's the case, I'm going to be worried that I've missed something. So I'm going to reconsider my options. Have I overlooked a patient who might potentially be septic? Or is this patient bleeding? Those patients tend to perk up briefly and then kind of flatten back out again. The third option would be that the patient looks worse after I've given my shock bolus. This would make me very worried that I've missed something. And the number one thing I'd consider under these circumstances is occult cardiac disease. This can be a real issue in cats. That's it for lesson 2. So let's think about our take-home messages. Number 1, really, really important that we know the signs that suggest a patient is in shock. So the signs of ineffective circulating volume. If you see that, message number 2, you must always identify the cause. We're going to talk more about making a replacement fluid plan in the next video.